All right, so we're now on part two of week four, the respiratory conditions. And in this particular PowerPoint, we're going to focus on asthma and COPD. So asthma and COPD review, I just wanted to give you an animated introduction review, just to review like what the consistent symptoms are to differentiate your typical asthma versus other COPD symptoms are.
Today I'll be starting a 4-video series on asthma and COPD, the two most common forms of obstructive lung disease. This first video will be to give a very brief introduction to those conditions, focusing on their definitions and how they relate to one another within the broader category of obstructive lung disease. The second video will discuss the pathogenesis and pathophysiology of the two conditions, and the third and fourth videos will cover the diagnosis and treatment of chronic stable disease and of acute exacerbations, respectively. The formal learning objectives for this introductory video are first, to define asthma, chronic bronchitis, emphysema, and the COPD, and second, to describe the relationship between those four diagnoses. As I started, asthma and COPD are both considered members of a category of chronic lung conditions called obstructive lung disease, named such because the single most important pathophysiologic feature in both is airway obstruction. There's a classical paradigm of obstructive lung disease, which has historically been represented by this Venn diagram. The diseases emphysema and chronic bronchitis are sometimes considered to be at two ends of the COPD spectrum, or more accurately, two overlapping sets of manifestations within COPD. As the diagram suggests, these three conditions, asthma, chronic bronchitis, and emphysema, are not mutually exclusive. Some patients have both emphysema and chronic bronchitis, some have asthma and emphysema, and so on and so forth. Unfortunately, despite the frequency with which this diagram has been reproduced over the years, it's not a particularly accurate or helpful representation. A more modern paradigm might look something like this. In this case, we still have asthma, chronic bronchitis, and emphysema, but the degrees of overlap are not equal. There are many more people with both chronic bronchitis and emphysema than either one of those with asthma. In addition, there are a few other members of the obstructive lung disease club. There is bronchiectasis, which is permanent enlargement of the airways leading to chronic bacterial colonization, frequent infections, excessive mucus production, and a chronic productive cough. There is cystic fibrosis, an autosomal recessive genetic disorder involving a membrane protein that acts as a chloride ion channel. Finally, a condition called allergic bronchopulmonary aspergillosis, which is a chronic allergic response to aspergillus colonization, which is most frequently seen in asthmatics. There's also a variation to this modern paradigm, which will help us understand how the term COPD fits into all these other diagnoses. And to understand the variation, I'll need to go over four definitions. Let's start with asthma. What exactly is it? The contemporary definition of asthma is that it's a chronic inflammatory disorder of the airways characterized by airway hyperresponsiveness to a variety of external stimuli, which results in episodic wheezing, dyspnea, and cough, and which is associated with variable airflow obstruction that is usually, but not always, reversible. How does that compare to chronic bronchitis? Chronic bronchitis is a chronic inflammatory disorder of the airway, resulting in a chronic productive cough with episodic wheezing, dyspnea, and acute exacerbations of that cough, which is usually, though not always, associated with incompletely reversible airflow obstruction. So the symptoms of asthma and chronic bronchitis sound kind of similar. Next is emphysema. This is a permanent enlargement of distal air spaces associated with destruction of airspace walls, that is, destruction of something which a pathologist refers to as the pulmonary acinus, which consists of respiratory bronchioles, alveolar ducts, and at the distalmost end of the airways, the alveoli themselves. You may note that while asthma and chronic bronchitis are defined largely based on symptoms, the definition of emphysema doesn't explicitly include symptoms. Finally, what is chronic obstructive pulmonary disease? This is a chronic inflammatory disorder of the airway associated with incompletely reversible airflow obstruction, which is usually progressive and which is characterized by episodic exacerbations. Okay, now those four definitions sound largely overlapping, which is partly why they are so tricky to distinguish in practice. So let me return to the Venn diagrams, but show you one that better illustrates exactly how COPD relates to the other diagnoses. So here we have something that looks similar to the first diagram we started with, only now there is much more overlap between chronic bronchitis and emphysema, since they usually but not always coexist. Then layered on top of this, I'll add in the finding of airway obstruction, which is defined by abnormal pulmonary function tests or tests of peak flow during exacerbations. So everyone with asthma has some degree of airway obstruction, and most people, though not all, with either chronic bronchitis and or emphysema also have airway obstruction. Importantly, there are some people with airway obstruction as determined by PFTs who have neither asthma, chronic bronchitis, nor emphysema. These would be the patients that have things like bronchiectasis and cystic fibrosis. And finally, here is how COPD fits in. So patients with COPD are those who have either chronic bronchitis and or emphysema who also have airway obstruction. I think it's easy to understand why doctors and patients alike get confused by the terms, which of course have evolved with time and may not even have universal consensus regarding their use today. I've heard statements from doctors that asthma and COPD are mutually exclusive, or that a diagnosis of chronic bronchitis requires abnormal PFTs, neither of which are true based on the modern conventional definition of these diseases. Nevertheless, the terms asthma, chronic bronchitis, emphysema, and COPD are still frequently mixed up. And
so I just want to clarify that so we're all clear. COPD can be used as an umbrella term. So COPD, being chronic obstructive pulmonary disease, is an umbrella term. And if you have asthma that is chronic, or you have a diagnosis of chronic bronchitis or emphysema, these all fall under the umbrella term of COPD. So you'll say to, you'll hear patients being referred to as, oh, this is a COPD. And what does that mean? Do they have emphysema? Do they have asthma? Do they have chronic bronchitis? Do they have both emphysema and asthma? That's very common. But I just want you to be very conscientious of the fact that COPD is an airway obstruction. And under that umbrella falls the three different diagnoses of emphysema, chronic bronchitis, and asthma. And keep in mind, it just is a differentiation in symptoms and how they present, although it is all the same concept of pathophysiology of airway obstruction. You want to differentiate the three just so you can treat them appropriately, especially with asthma, because there's different treatment modalities that will help alleviate those symptoms better than others. But just again, COPD is the umbrella term, and then you have the subsidiaries or the underlying conditions, asthma, chronic bronchitis, and or emphysema and keep in mind the three overlap in terms of symptomology. So sometimes you have both or, more than one disease factors. So that will all fall under the umbrella of COPD.
Great care must be taken to ensure that use is standardized in order to prevent confusion. That concludes this very brief introduction to some different forms of obstructive lung disease.
Okay.
The next video.
So let's continue on. So again, asthma, review of airway. So asthma can also be known as a reactive airway disease. It is defined as episodic attacks in that they are chronic, inflammatory, and obstructive disease of the airways. They have reversible hyperactivity of the bronchi and bronchioles to triggers with exacerbation mediators incite structural remodeling. Hypoxia is a universal finding during exacerbation, meaning they cannot breathe. Patients cannot breathe. They cannot get enough oxygen during an exacerbation of an asthma attack. So if you find a patient who can't breathe during an asthma attack, you are finding a very um, typical finding of an asthmatic. Again, hypoxia is a universal finding during an exacerbation. With acute bronchospasms, we're finding that the residual volume increases, that the PEFR diminishes, that they have an increased airway resistance, that they have decreased inspiratory capacity and expiratory volumes, that they have ventilation perfusion mismatching, they have altered arterial blood gas concentrations, and that they have respiratory alkalosis, and hypocapnia, which are common findings with each episode. As the acute attack resolves, there's a narrowing in larger airways, which tend to reverse first, and then the peripheral airways remain the most constricted. If the attack progresses and fails to reverse, they go into respiratory acidosis. They have an elevated arterial carbon dioxide concentration signals, which is impending of respiratory failure. And then they also have severe irreversible bronchoconstriction and inflammation, leading to status asthmaticus, which obviously can be fatal. A lot of this stuff is a review from your undergrad work, and I'm sure you guys remember this from your RN review. But these are acute findings that are pretty severe. And remember, as a nurse practitioner, if you find these findings, it is your responsibility to treat and diagnose and treat. So it's a bigger responsibility, obviously, in the NP role. Okay, so red flags in asthma. Patients who are new to your practice, you always want to inquire, have you ever been hospitalized for asthma? And if so, when was the last time they were hospitalized? You want to make sure you document that. Have they ever been intubated for asthma? How often? For how long? Have you ever taken steroids for your asthma? And if so, when was the last time they were on them? And how did they taper down off of them? How often do they go to the emergency room for their asthma attacks? And can they help? So all of these factors, when you inquire about them, can help identify if the patient has good control over their asthmatic issues, if they become very reactive, if they've had success with steroids, and how many times they've been intubated. The idea of knowing how many times your patient has been intubated also will be indicative to you about how immunocompromised your patient may be. All right, so just keep that in mind. You want to minimize how many times your patient's intubated at all costs. If you're finding they're intubated more frequently than not, you need to really look at their symptoms and how we're managing them to really increase the prevention of asthmatic attacks. With asthmatics, it's all about prevention, because the more they're intubated, the more they're at risk for more infection as well as death. So keep in mind with asthma, there's 100 million people worldwide who are diagnosed, 39 million in the USA, and there are $56 billion spent annually and directly, both indirectly and directly, on medical costs related to asthma. It can occur at any age. In African Americans, it's about 47%, which is greater than Caucasians. It's greater in females than males. In pediatric boys, it's greater than girls. Subjectively, you're going to see maybe or maybe not some wheezing, chest tightness, breathlessness, cough, air hunger, unable to speak in full sentences. They may inquire about the use of inhalers, the change in frequency, dose, and exposure to triggers. On exam, you're going to find like a runny nose, rhinorrhea, allergic shiners, cobblestonings. They may assume a tripod or other position, which is a posture to facilitate breathing. People don't fake when they can't breathe. So if you feel like at some level they're overdoing it, you really want to check their vitals, their O2 stats, their lab work, just to justify that, they may not be able to breathe, and that's why they're doing what they're doing. They may or may not have an inspiratory or expiratory wheeze, diminished breath sounds. They may be tachycardic, tachypneic, and they may have an eczema issue. So differentials, you want to differentiate if they have infections, vocal cord disorders, a variety of pulmonary and cardiovascular disorders, as well as the possibility of a foreign body. So this is the difference between a healthy airway, which is nice and open, and the airway is nice and healthy looking with no inflammation or swelling or condensation or condensity from mucus. And this is your asthmatic airway, where you have a lot of thickness and restrictiveness in the airway. And this little hole is a big difference versus this airway in terms of allowing airflow. So in terms of diagnostic airway pearls for asthma, so remember your clinical pearls, things you need to remember just to keep in mind that are very, very important. So differentials and pearls. So you want to consider infectious processes versus an allergic reaction as a standalone diagnosis or as triggers for asthma. So are there certain allergies that your asthmatic patient is having that are causing these asthmatic reactions? You know, are they allergic to peanut butter? Are they allergic to particular things? So you may want to refer to an allergist just to differentiate that and really sustain your diagnoses. Okay, is it a unilateral wheeze? Do we have a bronchogenic cancer, a foreign body, or bronchial stenosis? So really pay attention to your lung sounds. Do you only hear wheeze on one side? Why? Do you have crackles and rails, which could indicate a cardiac or pneumonia issue? In terms of the patient's cough, are they short of breath because of tuberculosis, a pulmonary emboli, mitral stenosis, ACE inhibitors, fungi, or other cough and infectious entities? Remember, you have all these symptoms that you're being presented with. Don't get stuck on a diagnosis when you have lots of options to what other diagnoses could be, especially if you don't find that the patient is getting any better with your current treatment plan. Remember, with asthma, we often see eczema, allergic rhinitis, or nocturnal awakening. In terms of gold standards, spirometry is the gold standard to differentiate and diagnose. Peak flows are not a substitute. And remember, not everyone who wheezes is asthmatic, and not all asthmatics wheeze. So listen to your asthmatic patient if they say they can't breathe. The presence of wheezing does not determine the acuity of an attack. In fact, if you have a lack of wheeze or robust air movement, this suggests very tight airways. So also, like if you can't hear any breath sounds, that's an indication that we are really in a bad place with our lungs. So just keep that in mind. Listen to your patient, no matter if they're asthmatic or not. You always want to listen to what your patient is telling you. Asthmatic diagnosis. So when it comes to your asthmatic patient, these are the diagnostics you want to start to consider. So episodic symptoms of airflow obstruction must be present. Airflow obstruction must be at least partially reversible, and the provider must have ruled out any alternative diagnoses. So pre and post bronchodilator PFT, pulmonary function test, is diagnosis made by demonstrating reversibility with bronchodilators, which is defined as greater than 10% increase in the FEV1 post 2 puffs of a short-acting beta agonist, a SABA. So in terms of this, your spirometry is going to be very helpful in terms of giving you FEC and FEV1 determinants. You want to have a chest X-ray, sorry guys, to show you if it's normal or hyperinfiltrated with the thickening of the bronchial wall of the lungs. And anything that shows diminished peripheral lung shows vascular shadows. You want to have a CBC with differential, and you want to have a SED rate to show if there's any inflammation. Intradermal testing, if the allergic status is significant, you want to definitely refer to an allergist. And you want to do an ABG if there is an emergency or if there's any concern about hypoxemia. So in terms of asthma management, we want to definitely manage our triggers, get rid of them if possible, or limit them. We want to do daily monitoring of peak flows. We want to have an asthma action plan. So as a practitioner, you sit down with the patient, you come up with the standardized action plan, which they have online, and you want to just go through it and kind of come up with a plan with your patient as to what things they're going to do to minimize any possibilities of exacerbations. And there's tools online that are evidence-based that you can definitely use to help guide your patient, and that will also show progress in terms of return to your practice for follow-up. You want to do a lot of extensive education about cleaning and vacuuming, making sure their bedroom is well vacuumed, pillowcases are changed, towels are changed, sheets are changed, bedrooms are swept and vacuumed. If they have carpet, you want to make sure they have a HEPA filter. Open those windows a couple of times a week just to get fresh air, especially during the winter, especially while they're cleaning, dusting, or using any chemicals to clean, to get rid of those chemical smells and get fresh air in the house. The biggest education I can tell you is to just make sure they're cleaning their bedrooms. That is the place you spend one of the most high levels of time of your life in. You spend at least minimum 8 hours at night to sleep. So you want to make sure patients are educated on the importance of cleaning those rooms and dusting, keeping minimal of items in those rooms, not a lot of clutter, because clutter develops dust, and that will help limit their asthmatic exacerbations. You want to educate them on taking their medications as prescribed and the importance of follow-up. Make sure they know how to use their albuterol nebulizer treatments up to 3 times every 20 minutes as needed. You want to consider steroids short-acting versus a long course, depending on what they've used in the past, what they're tolerant of, and if they have a pulmonologist, you definitely want to consult with them in terms of managing their asthma. The likelihood is if their asthma becomes uncontrolled, or if they start to have frequent attacks, you're going to want 100%. The minute they become diagnosed with asthma, you definitely want to refer them to a pulmonology. But if they start to have a frequent exacerbations and they're coming to see you as opposed to seeing the pulmonologist, that's when you want to get on the phone and consult with the pulmonologist just to make sure that you are following the correct treatment course based on the severity of the patient's symptoms. Again, obviously, emergency symptoms. If the patient's O2 stats remain low and they're not improving with all their medications and they're air hungry and they really don't look good, obviously you want to get them admitted to the hospital so they can be further managed. So we want to know the triggers of the asthma and the allergies. So what's causing the asthma to become exacerbated? What are the allergies? What are the environmental factors? Are they smoking? Are they using illicit drugs? Are they vaping? Are they eating a lot of highly salty foods with a lot of additives, like Chinese foods with MSG, or sugars, or any of those kinds of foods that are not good? Do they have a respiratory infection? And what are the common triggers and presentations for them in terms of that? Do they have a lot of stress? Is there a lot of dust in their home? Is there a lot of animals? Like, ask them about the cleanliness of their home. And keep in mind, not everybody's as conscientious as others about what cleanliness actually means. So you want to get some details, like how often is the house vacuumed? How often is it mopped? Do we have a cleaning lady? Do we clean ourselves? Is it who is cleaning the house and how often? Is there any mold issues, any leaks? So, these are all factors that could contribute to triggers affecting the environment, which could lead to allergens that are triggering asthma. All right, so in terms of peak flows and our peak flow testing, this is how we know, where the patient falls in terms of their use of their peak flow meter. And this will determine if their asthma therapy is working or not working. So they're in the green zone if their PEF is 80 to 100%, and they usually have no symptoms, which means their asthma control is adequate. And they're in the yellow zone if their PEF is 50 to 80%, They may say they have mild symptoms, no symptoms, maybe moderate. This is when we got to take caution. If they're in the red zone and their PEF is less than 50%, we're concerned. We need to definitely get a new treatment plan in place and reconsider our medication options. So again, mild, persistent, moderate persistent, severe persistent. This is where we go in terms of how we're prescribing and treating our maintenance medications, not just our rescue meds. It's based on our FEV values, our PEF or FEV1 values. Again, these patients can test these at home with their breathing machines. They can find out what their PEF value is a lot of the times at home. So they don't even have to come into the office, and we can already judge where they're at in terms of their symptoms classification. So here is a beautiful graph of how you would decide to prescribe whether a SABA, an inhaled corticosteroid, a leukotriene receptor agonist, or a LABA based on their symptoms. So step one is the controller and the reliever, and so on and so forth. I'll let you look at this, but this is very important because this is what will dictate in terms of evidence-based practice what the best treatment options are. So know these standards. Okay, so application to practice. Can you answer this? You have a 19-year-old female diagnosed with PFT with moderate persistent asthma. Using the tools of the guidelines, determine what medications might be prescribed for this patient, whether the type of medication education is required for the newly diagnosed asthmatic. So here's the self-management exacerbation chart and how you would initialize it. And then here's the medication. So rescue medication would be a SABA. A maintenance controller would usually be an inhaled corticosteroid. And then you have your other medication options depending on what symptoms are continuing to occur. Here is a beautiful graph from Allergy and Asthma Network.org of your short actings, your long actings, your inhaled corticosteroids, your combination meds, and your biologics. So you can look at this. These change pretty consistently because of drug pharmaceuticals. So you always want to try to keep abreast of it, but at the same time, the classifications always pretty much maintain the same. So asthma medication pearls. Okay, so generally, if a patient needs to be consistently using a SABA more than twice a week, they're not having adequate control. It's considered inadequate control, and you need to consider another medication. While providers tend to order albuterol 1 to 2 puffs Q4 to 6 hours PRN, explain to the patient that if they need to use that frequently, they need to be seen. Because if they're using it more often than every 6 hours, 1 to 2 puffs, something is going on. If they find they're using it more frequently at any point, something is wrong. Remember, when it comes to asthma, the more proactive you are, the better off the patient is, because they can go from bad to very bad very quickly. And you want to be more proactive than not to prevent that, like any kind of respiratory emergency from occurring. We want to teach the patients that we need to move up and down on the steps or scales depending on their needs at any particular time. So what does that mean? We just need to educate the patients to really make sure they're aware that if their asthma is acting up, so to speak, they need to be seen. They shouldn't be trying to treat themselves, because the problem is when a patient who has asthma or any kind of respiratory illness starts to get bad, they start to lose their ability to think clearly. Because remember, their respiratory illness goes from bad to bad very quickly. They start to lose oxygen. They're not thinking clearly. So then how do they treat themselves appropriately if they're not thinking clearly? This is why we need to get involved sooner than later. And if possible, we need to try to get their caregivers involved as well to educate them on how to respond appropriately if they find that their asthmatic patient or asthmatic family member is starting to decompensate. We need to teach them as well on the steps and scales depending on their needs. We need to consider immunotherapy or allergy shots if it's appropriate for the patient. Coffee, remember, contains a bronchodilator, and take a lot of caution with beta blockers or calcium channel blockers. Okay, so remember, asthma in summary, you want to make sure any newly diagnosed or maintenance treatment, you want to identify and diagnose the patient and use your guidelines, your asthmatic guidelines, because they're super appropriate evidence-based practice, and they're standardizations of care that will always back you up in your practice in terms of your patient's treatment plan. You want to teach the patient self-management, instruct on peak flows and the management chart in terms of filling it out. You want to really educate on when the patient should come into the office and when they should seek emergency care, as well as the importance of following up with their pulmonary and asthma educators and specialists. Obviously, if the patient has any acute or new asthma attacks, we want to assess the severity, their nebulizer treatments, the cause, consider steroids, consult, discuss their hospitalization or consider hospitalization if needed, and really make sure that the patient is conscious.
It's 8 o'clock.
To call 911 if they do go into any kind of respiratory distress issues. So at every visit, you as an NP, you want to make sure you're continually teaching and reinforcing all of these educational points, specifically what they need to look for in terms of their daily management, as well as their emergency signs and symptoms to report. You want to try to educate this with both the patient and the caregivers. You want to encourage ongoing and open communication with the patient and family. You want to review short-term goals agreed on at the initial visit. You want to review at the asthma action plan for worsening symptoms and exacerbations, as well as the daily self-management plan and the steps the patient needs to take to improve their triggers, if anything else, if nothing else. You want to supply the patients and their caregivers with appropriate educational materials for self-management and prevention. So what can we provide in terms of education, written instruction on managing an acute attack, medications, use of inhalers, the importance of cleaning up after pets and plants, the importance of vaccines, what to do when sick, how to handle triggers, when to follow up, how to exercise, when to slow down, when to know you're doing too much too quickly. Obviously, the importance of educating and encouraging smoking cessation, and family education on trigger smoking and cleaning of the house or the home. All right, let's get into COPD. Remember, this is an umbrella term. So COPD, characterized by the presence of airflow obstruction due to chronic bronchitis or emphysema, is progressively and largely irreversible. It is the third leading cause of death in the US. Mostly high risk are males, older age, cigarette smoking, reduced lung function, occupational exposures, air pollution, and really it's mostly cigarette smokers. 80–90% of the cases of COPD is because of smoking. So obviously it's chronic exposure to irritants. So chronic bronchitis is a productive coughing with excessive mucus for over 3 months for at least 2 consecutive years. And that's considered airway hypersecretion inflammation, versus emphysema, which is an irreversible enlargement of alveolar damage, where you have a loss of elastic recoil, which results in chronic hyperinflation, where you find that the expiratory phase is markedly prolonged. Emphysema patients have an increased shortness of breath on exertion with fatigue, hemoptysis, paroxysmal nocturnal dyspnea, and a loss of appetite. So we have pink puffers, which is primarily emphysema and severe dyspnea, versus blue bloaters, which is chronic bronchitis, which results predominantly from pulmonary hypertension. So pink puffers usually present with a relatively normal ABGs maintained due to high minute ventilation. And then blue bloaters usually are edematous and cyanotic. So COPD, you may be asymptomatic for years, and then all of a sudden we develop this chronic productive cough, aka chronic bronchitis, and increased shortness of breath or dyspnea on exertion. So the dyspnea on exertion is really more emphysema. So just keep that in mind. So dyspnea on exertion, that blowing out, that's very with a struggle or tight, is your emphysema. Those are your bloaters. They look like they're blowing up, right? Then you have your chronic bronchitis, which is more just of a chronic productive cough. But again, that falls under the realm of COPD. So if you have somebody with emphysema or you have somebody with chronic bronchitis or both, they are considered a COPDer. They are considered to have COPD. You don't need to differentiate between emphysema versus chronic bronchitis. We know they have COPD, so that falls under the umbrella of basically the same sort of treatment plan. So just keep that in mind. So these patients have fatigue, weakness, hemoptysis, remember throwing up of blood. They have loss of appetite, nausea, and dizziness. Their dyspnea on exertion is pretty advanced. It's pretty severe. They need 3 or 4 pillows. They cannot sleep laying flat. You know, paroxysmal nocturnal dyspnea, they just can't sleep laying flat. They can't breathe. So they have to sit upright. Most of these patients you'll find sleep in recliner chairs because they're sitting up most of the night. So COPD depends on the severity. They have distant breath sounds, expiratory wheeze, prolonged exhalation, neck vein distension. A lot of the times they have pedal and ankle edema, as well as clubbing and fatigue. So here is what a normal chest x-ray versus chronic obstructive pulmonary disease on the right, where we have evidence of hyperinflation. And look, here in the left, I want to just point out, like the chest x-ray shows you the landmarks that you're always looking for. Very important, okay? Aortic knob, pulmonary trunk, left atrial appendage. You have your right parenchymal stripe right here. You have your interlobar artery, right atrium, and the zygoesophageal recess. Okay, so in terms of diagnostic tests for COPD, you're looking at your PFTs, your chest x-rays, your CBCs, and your sputum with gram stain, as well as EKGs, depending on if there's a cardiac component. So COPD can definitely affect the quality of life. If they are end stage, you want to consider hospice. Even when you do smoking cessation, you know, it still helps, even if it's at the end, it can still help slow the rate of decline, regardless of the level of severity, which is pretty incredible. But again, you know, some of these patients, their quality of life is so centered around their smoking habit that you may find that it's not in their benefit to try to promote that, depending on where they're at, if they're ready or willing. So we have COPD classifications based on the GOLD guidelines. So we want to make sure we properly stage them, because this will definitely initiate and determine our management of these patients. So it all depends on their FEV. And based on that, we decide if they're mild, moderate, severe, or very severe to stage them. So your pharmacological therapy, you have your beta-2 antagonists, anticholinergics, double and triple combination preps, mucolytics, or your 4 phosphodiesterase 4 inhibitors, depending on what they need. So if they have severe COPD, we definitely want to refer to a pulmonologist, make sure they're getting their yearly influenza vaccine and pneumococcal vaccine. We want to work with them on their COPD management. So their management tools and guidelines, you can definitely find at the American Lung Association. And here is the link if you wanted to check that out. But that's where you would go to really fine tune their plan of care. This American Lung Association will give you the beautiful guidelines. You want to look at annual diagnostics to look for changes in the disease severity every year with their physicals in terms of spirometry, CBC with differential chemistry profile, and chest x-rays. So in terms of antibiotics in COPDers, you want to use antibiotics when they're having an exacerbation with the cardinal symptoms of dyspnea, sputum volume, like if they start to get a lot of sputum production, and sputum purulence, or need for mechanical ventilation. So if their severity of their respiratory infection becomes so bad that they have to be intubated, obviously we need antibiotics then. If their sputum becomes thicker and more prevalent, we need to treat them with antibiotics at that point. We also need to consider treatment if their shortness of breath becomes severe. So in exacerbations, systemic steroids shorten recovery time and improve lung function. They also improve oxygenation and risk of early relapse. So you definitely want to consider a short course of steroids, about 40 milligrams times 5 days. We do not recommend long tapers. You want to get them on and get them off. Long-term maintenance treatment is now discouraged. People get very addicted very quickly to steroids, and it's very hard to taper them off. So just keep that in mind. While steroids work, especially in patients with an allergic component, potential side effects on already compromised system should be weighed and carefully watched. So for sure. Remember, your diabetics, you're worried about their blood sugars. Anybody who's immunocompromised, you're worried about them as well. So this just talks about oxygen therapy in chronic respiratory failure. Shows it, it's shown to increase survival in patients with severe resting hypoxemia. So just keep that in mind. You're really looking at the symptoms of the patient. How do they feel with the use of oxygen? Does it help them? Does it improve their O2 stats? Does it improve their energy levels? Does it improve their sleep? This is how we really decide if they need, if the benefit of using it. Smoking cessation. So that's what we want to make sure we're educating our COPD patients on. Obviously, the importance of quitting smoking, getting their yearly flu shot. Any pulmonary rehab should be considered for all patients. If they have any kind of functional impairment from their lack of ability to breathe, as well as physical rehab. You want to consider any kind of physical therapy, and just discuss with the family, to keep the practitioners aware of any functional decline in the patient from the COPD. You want to talk about support groups. You want to educate on personal breathing, O2 therapy, assess for depression, and treat if necessary. And you also definitely want to go over advanced directives. All right, so end-stage COPDers are suffering. Keep that in mind. Patients that have COPD that are end-stage cannot breathe, and they are suffering. So at this point, you want to make their life as easy as possible. You want to consider hospice to give them palliative and just respite, whether it's pain management from their anxiety and their inability to breathe, or their comorbidities, as well as just relief at home and meeting their wishes to give them the optimal way to pass on without suffering any further. They need a lot of support besides just their home oxygen. They need a lot of support, both nutritionally and physically, to manage their basic ADLs. So just keep that in mind. All right, guys, thank you so much. Hopefully this was helpful, and I will see you next week.